Assalamu alaikum and hello everybody. My name is Dr. Mohammed Al-Jafawi. I'm a Kuwaiti Board of Internal Medicine resident, currently working with the COVID team Jahra Hospital. Today we are going to talk about the diagnosis and management of COVID-19 disease. This presentation is based on two articles, Diagnosis and Management of COVID-19 disease and Update on Evaluation and Management for COVID-19 patients. The links are in the description. They are open source documents. Symptoms of COVID-19 may vary. They range from fever, cough with or without sputum, dyspnea, upper respiratory infection symptoms. We can see that almost 50 to 80% of the patients have cough, 85% have fever, fatigue happens in almost 70%, dyspnea ranges from 20 to 40%. There are two clinical causes of this disease. The first one, which consists of these symptoms. The second course, which happens usually after 5 days from the start of these symptoms, and it consists of rapid clinical deterioration. Going for the lab evaluation, it is recommended to send for all of these labs. CBC with differential can be normal sometimes. Leukopenia can happen. Lymphopenia happens in more than 80% of the patients. Sometimes there is mild thrombocytopenia. Liver and renal function test, BUN and creatinine can be elevated sometimes. ALT and AST may be mildly elevated. Total bilirubin can be also elevated. Coagulation studies with D-dimer can be normal. D-dimer happens or sometimes happen to be high. You're going to look for DIC as it happens sometimes. For the PCR, sensitivity and specificity vary from each lab, so look at your own institution results. Respiratory virus panel, you may send for that if you're suspecting another virus. PCT is not routinely elevated. If it's elevated, you should suspect another diagnosis or superimposed bacterial infection. However, for CRP, it's routinely elevated and tends to be more elevated with the progression of the disease. Also, it's recommended to send for these labs. And for the G6PD, because chloroquine sometimes causes hemolytic anemia in G6PD patients, so it's recommended to send for that. Also, do an ECG, baseline ECG, to check for QT prolongation, as some of the medication we use sometimes causes QT prolongation. Also, it's recommended not to order sputum induction and to avoid bronchoscopy unless absolutely indicated. PFTs or spirometries are not indicated in these patients. There are some poor prognostic factors. The absolute lymphocytic count if it's less than 0.8, the LDH if it's more than 245, CRP if it's more than 100, the ferritin if it's more than 300, and the D-dimer if it's more than 1000, all considered as poor prognostic factors. Imaging, chest X-rays. Patchy granulopathy happens in 70% of the patients. Clear lungs are seen often in the early course of the disease. Rarely you can find pleural effusion, and it happens in almost 13% of the patients on one of the studies. CT scan of the chest. There was a trend toward doing a CT scan of the chest for these patients as it detects subtle changes. However, due to the unnecessary exposure during transport and the CT scan didn't alter the course of the management, now it's not recommended to do it unless you have an alternative diagnosis. Point of care ultrasound, now it's being used. You can find the B lines, pleural line thickening, consolidation with air bronchogram. To the treatment part, fluids. It's appeared to be that patients with COVID-19 are very sensitive to fluid overload. So it's recommended here, if the patient is normotensive, not to give IV fluid. And if the patient is hypotensive and clinically hypovolemic, we can consider a small dose of IV fluid. However, if he's hypotensive and clinically he's overloaded, it's recommended to give vasopressors for hypotension. If the patient is hypoxic and appears to be normotensive and requires oxygen, it's recommended to give a shot of Lasix. Also, it's recommended not to give boluses to correct lactate. And also it's recommended not to give maintenance IV fluid if the patient doesn't need that. And if the patient is in shock, which rarely happens at presentation, usually the shock is because of cytokine storm or myocarditis, both of which does not respond to IV fluid. Empirical antibiotics, it should be started if there is suspicion of a secondary infection. Nebulizers, due to the concern of aerosol spread, nebulizers should be converted to meter dose inhalers. For the NSAIDs, the WHO does not recommend against the use of NSAIDs. However, clinicians should consider an alternative option. Going to the ACE and ALPS, it have been a matter of discussion. However, the American College of Cardiology and the American Heart Association recommend against discontinuing ACE and ARBs if the patient was already on them. Steroids are not recommended unless there is another reason, like asthma exacerbation, COPD exacerbation, refractory shock, or evidence of cytokine storm. Cardiomyopathy. It's recommended to monitor for that, as almost 33% of the patients developed cardiomyopathy in one of the studies. It's recommended that you monitor for them with point-of-care ultrasound with BMP and treat for that if it happens. Anticoagulation. Prophylaxis is important because of findings of thrombosis with advanced disease. Other treatments, I'm going to talk about vitamin C. In the citrus allele trial, it was found that high levels of vitamin C led to the protection of lung epithelium in mice. The dose they recommended was an IV dose, a high dose, which you cannot achieve its concentration with an oral vitamin C. However, there is a concern that high doses of vitamin C can be a pro-oxidant and it can lead to an increased level of iron in the body. So you should read more about that. About vitamin C, the citrus allele trial found that in high concentration of vitamin C in the body, there was a protection of lung epithelium in mice. The doses they recommended to use was a high IV dose, which you cannot achieve with an oral vitamin C. However, we should keep in mind that high levels of vitamin C can be a pro-oxidant agent and it can lead to high levels of iron in the body. Hydroxychloroquine. It's recommended to give it in critically ill patients, not all. Also, azithromycin. It's also recommended to give it in critically ill patients. And it is found that a combination of azithromycin and hydroxychloroquine led to a lower viral load in patients. However, you should keep in mind that both of these agents lead to QT prolongation, so we should be careful about that and we should aggressively replete magnesium as potassium as needed. About tocilizumab, it's an immunosuppressive drug mainly used for the treatment of rheumatoid arthritis. It's an IL-6 inhibitor and it may have a role in cytokine storm for patients in shock. Management of hypoxemic respiratory failure. Oxygen can be given with nasal cannula, simple mask, or non-breather mask. We should consider early intubation to avoid emergency intubation and avoid the use of BiPAP or CPAP to reduce the risk of droplet spread or generating aerosols. We should use the rapid sequence intubation. Bag mask valve or ambo bag should not be used due to the risk of spreading droplets. Direct laryngoscopy should not be used. We should use video assisted one. Lung protective ventilation strategies should be used as per ARDS net protocols. We should prone and paralyze the patients as needed. Patient will likely require a prolonged duration of mechanical ventilation. Prognosis. Based on the experience in China, 80% of the patients had mild symptoms, 15% had moderate, and 5% had severe symptoms requiring mechanical ventilations. Most patients deteriorate gradually with a median of 9 days from symptoms onset to ICU admission. Pregnant women and children appear to have a better prognosis. Also, there are factors associated with worse outcomes, including increasing age, comorbidities such as diabetes, cardiovascular disease including hypertension and chronic lung disease, and a higher SOFA score upon admission. This is the last slide. Thank you for your attention and I hope you have enjoyed and benefited from the lecture. Stay safe.